recording now. So I'm just going to share my slides. Maybe Steph, if you could admit anybody, if I'm a bit delayed doing it, that would be great. So.
Oh, Jeanette, we're in the same meeting.
So thank you everyone for coming today. Really appreciate your time. So this is our third meeting for the Children's Asthma Network for Hampshire and the Isle of Wight. And today we've got a really pertinent subject. So we're talking about asthma diagnostics. And we've got some really good speakers, which I'll tell you about in a moment. So if you could mute your microphones, that would be appreciated. If you've got any questions, just pop them in the chat function. If the questions, there may be quite a few of them, so we'll try and answer them at the end if that's okay. So we'll try and get through the speakers and then go through the questions at the end, unless you've got a burning question. If you want to share your name and your work title, that's great as well. It's always good to sort of find out what people are doing. And we're recording the session and we'll share a link afterwards. So, and I was saying earlier, there's a target meeting in Southampton today, but we'll be sharing this recording with the people who weren't able to attend today. So we've got a good agenda today, so I'm just going to give a really brief update. I don't want to take up too much time because we've only got an hour. Then we've got Professor Gary Connett, who's going to talk about the new NICE BTS guidelines and implications for Hampshire and Isle of Wight. Hopefully Tracy Jones will be joining us, as she's a consultant clinical scientist from St Mary's on the Isle of Wight. She's going to be talking to us about their Community Diagnostic Centre and their Children and Young Persons Asthma Pathway over there, which sounds very exciting. And last but not least, we've got Catherine Crocker, who's a respiratory nurse specialist at Southampton Hospital, who's going to talk to us about this spirometry testing for primary care programme they've got running at University Hospital Southampton. So that'd be really interesting to hear about that. Like I said, hopefully at the end we'll have a good discussion about what has been shared today. And the proposed date for the next meeting will be Tuesday the 10th of June from 1 till 2. So just some quick updates. So there's been some changes to the GP contract for 2025 regarding diagnosis. So it's made it a lot clearer actually. And now when you're making a diagnosis of asthma, to get your QOF points, you'll be expected to have an objective record of an objective test, a record of that in the patient's notes in the 3 months prior to that diagnostic code being added, or 3 months post that diagnostic code being added to the notes. So this is in line with the NICE guidelines. So it does make it a lot clearer, because you can see on the left hand side it was all a bit confusing. So it should make it a lot better for primary care to get their QOF points. Obviously there's a time that you've got to get those diagnostic tests in, so that's going to be quite challenging potentially. Because fractional exhaled nitric oxide is in the guidelines as a first line test for asthma in children and adults, the ICB are developing a deployment plan, and Dr. Ben Green, who might want to comment on this a bit later on, is leading that piece of work, and it's going to be going to a primary care clinical reference group later next week, I believe. So watch this space. I don't know if there's any funding available, but I'm sure everybody will be told what has been developed as a result of that. So just to let you know, just some other quick updates. There's going to be a free national spirometry e-learning available after Easter. This doesn't replace formal training, but it will be a good sort of update if you're thinking about doing paediatrics, because there's a paediatric element of that. So that would be very useful to do. Or if you haven't done any training, but you've historically undertaken spirometry, that would be useful to complete as well. There is funding available for primary care to undertake a formal course, and that's with Education for Health. The link is on my slides, which I'll share widely, but there is funding available for anybody in primary care to get those courses done. There are asthma and COPD courses available as well. There aren't any actual paid funded courses for paediatric asthma, but luckily we've already got a free paediatric e-learning course, which is recommended for anybody who's seeing children with asthma to undertake, and that's available for e-learning for healthcare. Because FeNO is featured so heavily now in the NICE BTS guidelines, there's also some free FeNO e-learning, so we really encourage people to do that. It's completely free and it's on e-learning for healthcare as well. And if you're thinking about upskilling your members of staff, or you're a nurse in a GP practice who wants to undertake spirometry and pheno, or just feel more confident in seeing children with asthma, I'm very happy to come and do some clinics with you. I quite enjoy getting out and about and meeting people, and most people find it a really valuable experience. So do get in touch if you are interested. And one of my old colleagues, Maria Urton, she's the Asthma Lung UK respiratory champion for Hampshire and the Isle of Wight. She's running a respiratory champions network for Hampshire and the Isle of Wight, and she's holding regular meetings. It's an opportunity to network, chat about cases, learn from each other. So it's a virtual meeting, and the next one's on Thursday, the 10th of April, between 5 and 6. So if you want to contact her to be part of that group, her email is there, and there's a WhatsApp group that's been developed as part of that as well. And regionally, we've got a Southeast East region paediatric asthma group masterclass webinar that will be coming up very soon. So we'll share those details very soon. So Gary, over to you if that's okay.
Yeah, thank you, Emma, for that introduction. So my brief for this meeting was to give a little bit of a context about the diagnostic testing for asthma, as in the new NICE BTS sign guidance, which came out in November of last year, November, December, and put that really in the context of our pre-existing diagnostic pathways for asthma in children, and we accept that there's going to have to be a little bit of a change there, and I'll tell you what those are. We've already met and discussed and are taking forward what we think is a reasonable compromise in terms of being as far as possible consistent with national guidance, but also meeting local needs in terms of how to take asthma diagnosis forward. So our guidance, as I'm sure many of you are aware, is available on the ICB website on the respiratory page, and there's also access to the guidance through the PEER website. This is our Pediatric Innovation Education Research website. It's a secondary care, primarily secondary care kind of resource for guidelines, which we set up about 10 years ago now for our locality. And within that, we've got guidelines for asthma diagnosis and management, essentially identical to those which we have in the ICB. And the idea being is that we have consistent best practice, what we believe to be best practice, across our locality and across the different levels of patient care, from primary up into specialist care services. So that's all there. The diagnostic pathway will be updated in the light of recent national guidance. Maybe some controversy about the extent to which we are prepared to change those, but I'll take you through it, and I'd be interested to hear some feedback and discussions after the presentation. So next slide then, please. So this is the BTS sign NICE algorithm. This is not for pediatrics. I thought I'd just put it in for context. This is 16 years and above. And as Emma's already emphasized, there's very much a drive towards having objective evidence underlying a diagnosis of asthma. So that's very much a driver in this diagnostic algorithm. It's not a very clear flow to it, but I'll take you through it. The box on the left-hand side, top left, in pink, is to do a pheno test. It does have blood eosinophils or pheno there as an alternative. It says a pheno level of above 50 parts per billion, quite a high threshold for airways inflammometry measurements to support a diagnosis, can be used as a diagnostic test in the context of a patient with suggestive symptoms for a diagnosis of asthma. So a big kind of theme in these new guidelines is that whilst we've got objective testing here, they must be within the context of a patient that looks and sounds like an asthmatic, as well as the results of the objective tests. They've also got in there an eosinophil count above the laboratory reference range. I'm not quite sure what to make of that. We'll move on. Bronchodilator reversibility. variability. Spirometry is the next test if you don't hit that 50 parts per billion threshold. And as we all know, asthma is a disease of smooth muscle, which is inappropriately bronchoconstricting the airways, causing narrowing the airways, and the ability to demonstrate the reversibility of that smooth muscle contraction with a bronchodilator is a very good indicator of reversible airways obstruction, consistent with the diagnosis of what ultimately is asthma. You can tell I'm a big fan of spirometry. So the threshold's there for significant reversibility. 10% or more of predicted normal is what we're using, which is consistent with the European guidelines for reversibility testing using spirometry in children. All good. Moving on to that, if you haven't got reversibility, you haven't got a raised FeNO, recommending peak expiratory flow rate variability, and have chosen the 20% variability in terms of probably diurnal variation as an indicator of variability in airflow obstruction. I'm not going to comment on that. That's adult data that's defined that parameter. And then finally, there's bronchial challenge testing, looking for the evidence of a twitchy airway, histamine or methacholine challenges to look at the threshold at which the airways become bronchoconstricted beyond that which is normally expected. A specialized test, which I don't think is certainly not available in pediatrics, but something that would be increasingly expected, I guess, at a secondary care level for patients to support a diagnosis of asthma. And if you don't tick any of those boxes, then, well, maybe it's something else and consideration of differential diagnosis. So that's the adult guidance. If we just click now to the next slide, which is a similar algorithm, and this is for pediatrics 5 to 16 years of age. Again, the emphasis being a history suggesting asthma, not much information about what that history looks like or what those symptoms are. It has to be said, which I think is a little bit helpful, if I'm honest. Again, FeNO first line test, just to remind you, you need to do FeNO before you do spirometry, because the results are less reliable having done a forced expiratory maneuver. So FeNO always comes first in the diagnostic algorithm. They've got a lower threshold for the level at which asthma is highly suspected, of 35 parts per billion. So that's less than the 50 for adults. Some devil in the detail there on the number score. That's quite a high level, I would say, in pediatrics, and it's a high bar. So it's not necessarily going to pick up a large number of patients, and certainly FeNO levels below that in pediatrics can be consistent with the diagnosis. Next, we've got bronchodilator reversibility testing, and we've got similar times to parameters, about 10% or more from predicted normals, and that's consistent with what we're recommending locally. Next is peak flow variability. We've got a 20% variability, the same as the adults. And then the thing that's new here in the pediatric practice nationally is that if we haven't got this evidence for the airway disease in terms of relation of inflammatory markers for airway inflammation, reversibility of smooth muscle contraction, or variability in bronchial airway diameter and variability in airflow obstruction, then there's this characterization of atopy on the assumption that if you have wheezy symptoms, symptoms suggesting asthma, and you have an atopic diathesis in some way as characterized by skin prick testing for house dust mite, eosinophils or IgE, then you're atopic and you're got respiratory symptoms, so you probably got asthma. And so therefore you get treatment on the basis of those objective tests. Controversial, I think, and controversial because not by any means, and certainly in primary care, do all children with asthma in childhood have an obvious atopic diathesis, and this will also be occurring in patients who may have allergic rhinitis, eczema, other atopic illnesses, which will give them evidence of sensitization, eosinophilia, and maybe a raised IgE count. without necessarily having airways disease. You don't necessarily get atopic illness in all parts of the body, skin, nose, and airway. So that's the pediatric diagnostic. So let's move on, please. So this is our, it's a bit small on the screen, isn't it? I hope you can see it. This is our existing, and it's our pre-existing guideline for asthma diagnosis in 12 to 17-year-olds. We've got two subtly different algorithms for different age groups, and I'll explain why. We hope helpfully try to give people an indication of when to suspect asthma on the basis of symptoms, and that was consistent with the previous BTS NICE guidance. More than one of the following symptoms recurring more than 3 times a week. So the emphasis there is really trying not to make people diagnose asthma on the basis of cough alone, and emphasizing the importance of wheeze, breathlessness, and then there's chest tightness there. So symptoms which are specifically related to airways obstruction, smooth muscle contraction. That can occur with cough, but also cough has many other causes in childhood. So we're trying to make that point about more than one of those symptoms. We measure fractional FeNO levels first as available. And again, the emphasis is on an increased use of FeNO. FeNO is quite difficult in small children, and in fact, we get spirometry more successfully in our school-age children in the younger ages than we do FeNO. It's not an easy test to do, and you'll hear a bit more about that, I think, from Catherine later on this morning. Then we go on to do reversibility testing. Got the same parameters around a change of 10% from predicted normal. We give advice on the dose of salbutamol to give. It's an arbitrary dose. There's no real evidence for that amount. And then we go on to consider the use of looking at peak flow based on a FeNO level of 25. Now we're going to have that 35 level, I think, at the top of this. We're going to go with the national guidance and say, yeah, if you hit 35 and above, then that's consistent and you can make a diagnosis, although I'd still like to have spirometry personally for my patients to help assess severity. And then we're keeping our 25 level there as a guidance as to whether to go on to do further testing or whether to consider alternative diagnoses. Where I think we do differ in the national guidance, and it's perhaps less than it might appear, is when we would consider a trial of treatment if symptoms are highly suggestive. So the national guidance does say, if they're severe, well, just get on with it and treat them, which is common sense, I would suggest, and we should do that. But I think it's important to recognise, and I have got data which I can produce to support all of this. I won't go into it now, but the atopy diathesis as a basis for asthma in childhood is not robust. I get the need for an objective test that might support a diagnosis, but I'm not sure a test of something other than airway disease is necessarily characterizing. The sensitivity of the atopic diathesis to base a diagnosis in the presence of symptoms is low, and I worry about under treatment and under diagnosis. So we're asking for common sense and pragmatic approaches, and if we're unable to get objective evidence, having tried, and I still emphasize and think it's important that we do go down this pathway as being driven nationally, we still consider a trial of treatment, but with some clear caveats around it, saying that after an 8-week trial of treatment, if it ain't working, well, we consider alternative diagnoses, and if it has worked, we stop treatment and then only restart if symptoms recur. So we're trying to have a safe practice here that doesn't miss patients and doesn't result in over treatment and over diagnosis. So that's what we've got locally, and as I say, we will fine tune it with that 35 level to be consistent nationally, and this is based very much and consistent with European guidance, which predates our NICE sign BTS guidance as well. So next slide, please. And this is our 6 to 11-year-old guidance. It's essentially the same, the same algorithm as you've just seen. The only difference is what the trial of treatment looks like. And we still think that first-line prevention treatment for asthma in this age group is low-dose inhaled corticosteroids with, as required, short-acting beta agonist SABA treatment. The previous guideline had a trial of MART as our first-line prevention treatment using a combination inhaler containing an inhaled corticosteroid and a long-acting beta agonist of rapid onset long-acting beta agonist, eformoterol effectively. So that's the only real difference there between those two guidelines. There's also, I didn't mention on the last slide, but a little bit of information there around interpreting FeNO levels. And, I've made the point there. This is with the 20, with our 25 cutoff. 50% of childhood asthma will not have a raised FeNO. That it's not that differentiating, and the presence of any other atopic illness will compound a FeNO result, because we know that children with allergic rhinitis have high FeNO levels, irrespective of whether or not they have asthma. So it's there's a lot of devil in the detail there. So that's our local guidance. And I think we're asking for common sense and pragmatism, I think, really, and having a place of a trial of treatment still, which is perhaps not quite emphasised in the same way in the national guidance unless symptoms are severe. But the caveat, of course, is that it's a trial, and we do discontinue if not effective, and consider the alternative diagnoses, and if symptoms resolve, only reintroduce asthma treatment if the symptoms recur, which I think is the best way forward, personally. And it's not just me. This has been through a whole bunch of colleagues across the region at primary and secondary care levels. So next slide, please. This is just a little kind of a taster of, we're trying to think about what to do in preschool wheeze. And I don't think, in this age group, you can do objective tests. The atopic diathesis is not really relevant to patterns of wheezing in this age group. And our current treatment approaches are not particularly effective. So, we have a huge number of children, preschool children, pitching up with acute, recurrent, intermittent viral-associated wheezing. And we know from the evidence base that regular inhaled steroids does not impact on this pattern of illness. All the things you learn about asthma in childhood don't apply to preschool children. And we have to have a different approach. And what we're toying with is the concept of intermittent inhaled steroids for intermittent viral associated wheeze. The dose we're suggesting is relatively low compared to the evidence for effectiveness of much higher doses, but most of us feel uncomfortable about using those very high doses and the potential for overtreatment with steroids and the risk of side effects. So that's something that we're toying with at the moment, and getting feedback from colleagues at primary secondary care as to how we might introduce this as a change in practice. The national guidance for diagnosis in preschool wheeze doesn't exist. There isn't any. And I would advocate for the fact that we don't diagnose asthma in preschool children. I think it creates all sorts of negative narratives and expectations of chronic illness, which are just not consistent with the evidence from prospective studies in this age group. So we're trying to take a different approach here, but it's work in progress. So I'll stop there. Thanks, Emma. Over to you.
Thanks, Gary. That's great. So next we should have Tracy Jones, who's from the Isle of Wight St Mary's CDC. Are you there?
Hello,
Tracy. Oh, hi.
I am, yeah.
Thanks for coming.
That's okay. Great. Thank you for inviting us. I do have Stephanie Russell with us, who's our operations manager for the CDC as well, just in case you have any questions around what we're developing.
Oh, perfect. Do you mind? I'll just mention Paul said, and thanks for coming today. Is it all right if we take questions right at the end? Is that all right? Or just pop it in the chat, just because we always run out of time. But thank you. So Tracy, brilliant.
Lovely.
If you want to get going,
so if you want to go over to our first slide. So we haven't gone live yet with our GP practices, but we are already seeing referrals within the acute system from patients we weren't seeing previously from our paediatricians. So these are just some of the things that we have done and some of the bits and pieces for the pathway we're still working on. So we had a GP engagement open evening, which we had our GPs attend. It wasn't as well attended as one would hope, but the people who came were really engaged. They were really impressed with the area and with the pathways that we were developing. So we've also attended the primary care meetings to try and keep that GP engagement and see kind of what they want, what would work for them. So we do attend those regularly. We have a standard operating procedure that has gone through our clinical standards group, specifically for children, that's completed. We've got some areas we are going to slightly change in it following some discussions with our paediatrician practitioner. We also have a patient leaflet and questionnaire that we've designed particularly to children because we were mainly adults before, other than the odd CF child. So we have a questionnaire that works on faces and visual things that they can circle, and then some parts of it for the parents as well, so we can gauge what sort of children are coming through the service. And then the leaflet is also very pictorial. So whereas our adult leaflet is very descriptive about what you're coming for, the leaflet actually has lots of pictures in. The pictures the patients can pick when they have incentive training, when we do the spiros. So those are in the appendices if you'd like to look at them. We've also developed a referral criteria. So we have a pro forma that's really clear for the GPs to fill in. And part of that is the BTS guidelines about when they should be referring to our asthma and allergy colleagues. We're not looking at those acute patients. So if they've had a hospital admission or they've been to ED twice or more in that 12 months, we're asking them to refer them directly to our asthma and allergy department. We're looking at those patients that we don't have a diagnosis for. They haven't got spirometry in the GP practice, and that's what we're offering. We're also working on the DOPS, which is really huge to try and narrow it down. So again, it's very clear what patients we should be getting through the door. And if it's, you know, patients are acutely unwell, they should be being directed to asthma and allergy. And then all of the people who do spirometry, I mean, they're all already adult spirometry competent. They've done the RTP training. They've all done their portfolios. So they're now topping up with the paediatric side of it, which is going really well. So that's really good. The things that we are hoping to go live. So we were looking at August 2025 for GPs, but I think we'll be ready before then. We're already open to our acute colleagues. We nearly have everything in place. It's just nailing a few bits and pieces down, and I think we'll be ready to go live with our GP practices. So shall we look at the next slide, please? So this just maps out what we've done so far, where we are. And like I said, we were aiming for the end of July, August, but I think we will be ahead of that. We've had brilliant engagement for the paediatricians who are already using the service. So that's really helped to drive this along. So next slide, please. So this is our pathway, which looks very messy, I know, but what we've tried to include is not just our spirometry and pheno, also looking at smoking and vaping in our children, and also secondhand smoke. So I attended a tobacco dependency meeting, and it became very obvious with our patient groups it isn't just about their own smoking in children, and therefore we are asking if anybody smokes in the house, and we are doing a CO monitor on those children and offering smoking advice if required. So our pathway has two arms. Patients are either referred in through primary care or our secondary care route. In primary care, they are coming via e-referrals via the pro forma that's in the appendices. I triage all of those to make sure, one, they're appropriate and they've been filled in correctly. And if they need to be triaged directly to asthma and allergy because they're not appropriate for this pathway, I will be referring those patients directly on, not back to the GP and delaying the pathway. The appointments then made by our admin team. Patient comes for their appointment. If they don't attend, we do send them a second appointment or a letter asking them to contact us within a 4-week period to rebook. They come for their appointment, they have their tests, whether that is pheno, spirometry, reversibility, CO monitoring. We're going to check their inhaler technique, because what we're finding from our acute patients, lots of our paediatric patients are on inhalers, but their phenos are through the roof. So they're obviously not taking their inhalers, and on questioning, often it will be, yeah, they haven't taken it for about a week or a few days. So we're doing some work around their inhalers. And then a report is produced, written up with diagnostic information and sent back to the GP. If we have any patients that come through this pathway that I'm particularly concerned about, because it is senior clinical scientists signing off all the reports, again, we have access to our asthma and allergy colleagues to fast track these patients. For our acute bit of the pathway, they get all of the same things, but because they sit within acute, they also have access to exercise-induced asthma testing, and they have access to methacholine challenge testing, which is available to them from this pathway, and they're already using those options for some of their patients. And then next slide just shows the appendices, which is our leaflet, the referral process, and our questionnaire.
Perfect. Thank you, Tracy.
Thank
That's
you.
Really interesting. And I'm sure there'll be lots of questions about that. But the Isle of Wight are very, very lucky to have your service. So next we've got Catherine Crocker, who's going to talk to us about what's on offer from University Hospital Southampton. Thank you, Catherine.
Hi, Emma. Thank you. So as Emma has already introduced me, I'm Catherine, one of the paediatric respiratory nurses here at Southampton Children's Hospital. Unfortunately, my colleague Asha, who is our brains behind this service, is unwell, so can't be here today. So we'll proceed to the next slide. So Gary's already covered this, so actually we can skip this slide and the next one. We all know that spirometry and pheno features highly in that diagnostic algorithm. So the spirometry commissioning guidance that was published in 2020 stated that there are challenges in having enough trained healthcare professionals who can administer and interpret those spirometry tests, and that's both in primary and secondary care. There's a very small chapter that covers spirometry in children, but it does state that there's an expectation that healthcare professionals that are already competent in testing adults would be deemed to be competent to perform the tests in those older age groups, so between 12 and 16. It then advises that healthcare professionals that are performing spirometry in younger children, so the 5 to 12-year-olds, must have appropriate experience and training in paediatric spirometry. They do acknowledge that children over the age of 8 have the ability to perform spirometry more consistently. The guidance also suggests that from 2020 to 2024, there'll be a targeted investment to train existing staff in spirometry, supported through primary care network training hubs. Now, I can't comment on whether this has happened or not, but to many of us that work in paediatrics, it feels like children and young people can get forgotten, as our patient groups are relatively small compared to the large population of adults. I'm prepared to be challenged on this, but our understanding is that money was allocated to GP practices across Hampshire and Isle of Wight to support spirometry testing. We know of 15 surgeries in our ICB that are not part of that localised incentive scheme, so they're unable to offer testing to any of their patients. And we also know that local diagnostic hubs have been slow to start. So we saw an increase in referrals for diagnostic testing from primary care. Currently, our waiting lists to see a paediatric respiratory consultant is about 6 months for a routine appointment, and that's similar in our general paediatric consultants as well. Our team here is a tertiary centre, and we accept referrals from across the Wessex region. So we wondered if we could see a small group of patients for spirometry only, with results being fed back to the GP within our current workload. And this would free up those consultant appointments for secondary or tertiary referrals. And as I've already touched, we feel very lucky that we have got our own paediatric respiratory physiologist that works in our team. Next slide, please. So we decided to use ASHA's expertise for those in the lower age group, so those children who are 6 or 7, who may need extra coaching to perform those tests and then get consistent results. We also decided that we'd be able to offer the service to all children and young people aged between 6 and 17 if their GP was not part of the localised incentive scheme. We started accepting referrals in March 2024. All patients were offered an appointment at Southampton General Hospital for pheno, spirometry and bronchodilator reversibility with ASHA, our experienced paediatric physiologist, and a trained nurse was available to give salbutamol for the reversibility. Next slide, please. So since March 24, we've received 118 referrals. We've seen 44 patients, and we've rejected 36 patients. And most of those rejections have been because the children have been over the age of 8 and their GP practices should be able to perform spirometry themselves. We've got a current waiting list of about 32 patients. Uptake has been really good. We've only had 6 was not brought. And as you can see, 3 of them were rebooked and completed and 3 were discharged back to the GP. The mean age of the children that we've seen is about 8.5, and approximately 50% of those patients were in that lower age group, so those 6 and 7-year-olds. So next slide. We'll look at the results that we obtained. So about 23% of our patients weren't able to complete the pheno testing, and that's pretty comparable across reports from other centres. Of those that were able to complete the test, 24% of them had abnormal results. And when I talk about abnormal results, I mean the over 35 parts per billion. For spirometry, we had a similar amount of patients that were able to complete it, and we needed to make sure that their results were in line with the quality criteria that was set by the ARTP. So about 72% of them did get those results. So of those patients, 11 of them had abnormal spirometry, and about 50% of them showed reversibility. Unfortunately, I don't have the data on how many children were already on inhaled corticosteroids, because as we've already touched on, we know that this may affect the results of reversibility testing. Next slide, please. So these are the problems and limitations that we have come up against or we've thought about. Cost is a massive factor for a lot of our families these days in the cost of living crisis. The furthest away GP surgery we've got is a 36-mile round trip. Once you've arrived and found a parking space, which is quite difficult, you get to pay between £2.70 and £4.90 for the privilege of that parking space. And our hospital is not the easiest of places to access by public transport, especially if patients are travelling outside the local postcode, so SO15. It can involve multiple bus and train journeys. The cost of time is difficult to work out, but children have to miss a proportion of the school day, and parents and carers may have to take time off work to enable them to bring the children to the appointments. It can be frustrating for some of our families that we cannot give a diagnosis in the clinic, but we give a clear explanation that we have only been asked to perform the tests and that the results will be sent back to the GP for interpretation. And usually this reassures them, much in the same way as if they've been referred for blood tests or x-rays. We do feel it's really important that this is explained to the families by the referrer so they know what to expect when they get to us. And then finally, previous written information was outdated and didn't reflect the current practice or current processes, so we weren't able to use it. Because of our communication policy, any patient information, any written patient information, has to go through the comms department and be approved by our policies review group, and this is a lengthy process. So we weren't able to provide written information prior to the appointment. All information was given in a telephone call, which, as we know, is obviously not ideal. Next slide, please. So what's next for us here? We're doing an evaluation of our clinic using the Friends and Family test. We now have a patient information leaflet that will be sent out to each patient prior to their appointment. Our physiologist is starting to undertake her competencies in administering salbutamol, so this will then free up the trained nurse. Emma, as she's already said, is offering to provide continued support for primary care. And as you would expect, any expansion in our service would need investment. Leicester ICB funded the first UK asthma hub for children and young people to provide post-attack reviews along with education, but more importantly, they were also able to offer the opportunity to carry out diagnostic lung function tests. So they have recently reviewed that service. They saw 266 patients and 231 of them completed first-line tests, and asthma was confirmed in about 31% of those patients. There's many models out there that show cost savings in adults who have an accurate diagnosis of asthma, and I'm sure this can be replicated in the paediatric models as well. But the services have to meet the needs of our patients. Bringing well patients into a hospital environment just doesn't feel like the right thing to do. But we know that there's a lack of appropriately trained staff in the community to deliver these services to our paediatric population. And there are many different ways of delivering these services, but investment is needed for this specific population. The 2014 NRAD report that I'm sure you're all aware of found that about 14% of deaths occurred in patients under the age of 19, and only 4% of those children and young people were judged to have received care that reflected good practice. An accurate diagnosis is a part of this good practice. So I just wanted to finish on what I feel is the most important message. And that is that the majority of asthma starts in childhood, and anything we do now is going to impact on their future lung health. We only get one set of lungs, so we really need to set up our services that meet the needs of our patients and their future lung health. Happy to try and answer any questions if I can.
Thanks, Catherine. That was brilliant. And I think what you ended on there is really, really valuable. You know, it's all about making sure children lead, you know, happy, successful lives. And it does, you know, the lifespan, we're thinking about a lifespan of a patient, aren't we? So it needs to start in their childhood. So getting it right early on.
Credit to you, Emma, for that little ending there, because that was what we talked about yesterday. So thank you.
Yeah, no, but you know, what you're delivering at UHS is a really good service, which is underfunded. It isn't funded, is it? And it needs to be, and we need to. Something needs to happen in Hampshire. Obviously, the Isle of Wight just sounds amazing.
It does,
what they're offering there. So, but that's part of a community diagnostic centre, so it's quite a different offering, and it's funded. But the other community diagnostic centres didn't go for the funding for the paediatrics, which is a real shame. So I'll just come out of that. Anyway, so it looks, has anybody got questions? Let's have a look at the chat, or does anyone want to put their hands up? I think Paul Seddon had his hand up very early on. Yeah, Paul, do you want to contribute?
Hi. Yes, I put my other question in the chat, but my question at the moment is, are there other CDCs across Hampshire who are already offering adult spirometry who would be interested in offering a service for children as well?
Yeah, that might be a question for Ben, actually. So I have trouble contacting the CDCs. Well, Steph might be able to answer that as well, actually. Steph, do you know?
I just thought I could potentially come in on that one. We have a network amongst the CDCs, so I'm aware that respiratory physiology is a key modality for all of the CDCs to deliver. So all of them should be delivering spirometry to adults. In terms of paediatrics, when the CDC program was initially launched, there was no reference to paediatric care, so a lot of them have been kind of developed with adults in mind. We were relatively unique on the island in that our CDC is situated on our healthcare campus, and we had a children's waiting area facility within that. So we were the first ones that were considered best placed to try and do this. However, new pathway development funding offer did come out at the end of last week, and CYP Asthma is a pathway priority coming out of that for NHSE. So all CDC leads will be being re-offered that opportunity to apply for funding support to get these pathways up and running.
Great, thank you. That's good news.
Yeah, that's good to hear. That should have gone through to the ICB then, shouldn't it, that offer? So I haven't heard about it. Probably Gary hasn't either. So we'll maybe contact Jeanette to find out about a bit more about that if you know, or Anthony might know about that, so we can sort of chase up with the other CDCs.
It comes through to the CDC program, Emma. So Ted
okay.
Moller or Heidi Robinson would probably be best placed to advise.
Yeah. Okay. So I did speak to the Southampton CDC person. They didn't feel quite prepared enough at the middle of last year, because they're still setting up for adults. But that sounds like a good opportunity. But yeah, I'll contact them. Thank you. Tracy, did you want to say anything there?
Yeah, I was just going to add on to what Steph said. I mean, we're quite unique because our diagnostic centre is built on our acute area, so we're able to share our skills. So the physiology team that runs across acute and the CDC, we were already doing CF children within acute. So lots of us already had the skills, and because we rotate between the two areas, it was a quick, easy win to develop it for us. And then just offer the staff who are onboarding and new the ARTP portfolio for the paediatric side. So we have been really lucky here because it happens to be on the trust side.
Yeah, and your facilities look amazing, actually. So yeah, I'd love to come over and have a look at them. But you know, we're really lucky that you're there and have got that amazing facility, and it's a really good model to sort of share with everyone else. If you do have meetings with the other CDCs, sharing your experience with them of delivering paediatric pheno and spirometry would be really valuable, I think, because I think there is a bit of a fear of working with children. They're not that bad, really. I quite like it. Has anyone got any other questions, or I'll just go through the questions in the chat? No? Okay. So, Paul, you mentioned the Wessex pathway looks good. My only suggestion would be that in those who have a trial of therapy, then stop and symptoms recur, to take the opportunity to measure pheno and bronchodilator responsiveness again.
Really good point.
Yeah, even children with asthma don't consistently have.
Yeah, I think that's a great suggestion, and I think I should take that forward. That's as we all know, asthma is a variable disease that comes and goes and isn't necessarily identifiable at the time of diagnostic testing. So if symptoms recur, retest. Yeah, really good point.
I guess it's just if there's that opportunity to get the test, GP practices, there might be a 6-week wait to get that test done.
Sure. I wonder, Emma, if I could just ask Ben's on the line, and it'd be really good to have his insights and comments on the atopic diathesis aspect of the pathways, diagnostic pathways, because it's new, isn't
it? We don't have that in the adult pathway. Obviously, I've got no experience of looking after kids. From an adult point of view, we want to follow NICE guidance, but we have to be pragmatic. So we are going to put in an additional step prior to beta-choline challenge testing, which we have in all of our acute trusts, and obviously we can do in adults, you can't do in kids. But we would still go for a trial of treatment before methacholine challenge testing. So the reason I say this is we're adding in a step to the NICE guidance to make it more pragmatic and manageable. And I see what you propose in kids of a trial of treatment is exactly the same pragmatic approach. You are you're doing it as instead of that last step, but I still see it as you're still going to look at whether the patient's eosinophil count is above 0.5, aren't you? You're still going to look at whether they're atopic. So that thought process is still going through the diagnostic algorithm, and you're just adding a trial of treatment in, which seems very reasonable.
No, thank you. It's reassuring to hear that you're being pragmatic in adults as well as in.
Well, we simply don't have enough capacity for doing methacholine challenge testing on all the people who would fall off the diagnostic pathway. In your case, you're adding in another process for people where there is diagnostic doubt, aren't you? So
absolutely. There is methacholine. I didn't mention it, but on the paediatric diagnostic algorithm, there is methacholine suggested as being part of the referral for testing in paediatrics. And I can tell you that we're looking at being able to do that in our own centre, and I know that there's no one else. Probably in the south of England that does it. It's all theoretical really, and the practical experience of doing that is very limited in the UK, and controversial. It's a population parameter, isn't it? It picks up changes at a population level, but for individual patients, it's less selective, I think. So I think there's controversy there.
We're not as quick to do blood tests on children as you are in adults either. So we wouldn't be checking eosinophils and IgE at that early diagnostic stage. It's more towards a severe pathway that we'd look at blood results.
Yeah. Go on, Ben.
If I may, just to update you on what's happening with Pheno, there is a real enthusiasm within the local care team to be delivering Pheno testing in primary care. The clinical case has gone to the clinical reference group for discussion this week. There is no deployment or business case yet, deployment plan or business case as yet. But we're really optimistic in the respiratory network that there will be a funded primary care Pheno offering. How that would look isn't yet decided. I'm interested for your opinions about whether it would be useful to do it at practice level. It's not thought to be practical at practice level because of the risk of consumables running out of date, really. So at PCN level is really what we would be looking at funding in primary care. But just like the spirometry, there would still be the issue of are providers confident enough and competent enough to do Pheno in kids? So we may still run into some of the same problems. And really what we want is our CDCs to take up the offering of pathway development funding to be able to do paediatric testing. The problem is it's a big ask for the CDCs because they don't currently have the infrastructure for kids waiting areas and things like that. And the safeguarding needs to go around having kids into your facility. So I think it's a bigger ask than might initially seem to be the case.
Just a feedback on that. So GP practices don't have kids waiting areas. It's a mixed bag of people who go to a GP practice. There's nothing specific for children. They've got rid of all the toys and everything like that. So one of the CDCs mentioned that before, and I mentioned it, I think, to Catherine, and we were like, well, actually, a GP practice doesn't have specific facilities for children, do they? So I don't think that should be a barrier, really.
Stephanie, you've been through the process. How did you find that?
I think when we were designing the facility, it did come up a need for a children's separate waiting area because we support some of the paediatric outpatients. For the most part, paediatric outpatients happens in its own a kind of isolated environment, but because we are co-located with fracture clinics, that it was felt that there was a need to have that availability. We've also had it raised through the programme a need to explore I've completely forgot the play specialist, that's the word I wanted, engagement in the pathway and having play resources. What we've fed back through our kind of pathway development is that we need the children to be quite focused as opposed to being distracted like they are with something like a blood test, and therefore our approach has been slightly different. I don't think not having a waiting area would necessarily stop services, but I could imagine it coming up through the estates arm of their programs. I did just want to note, Ben, when you were raising about pheno potentially being offered within primary care, is that something that the CDC programme is brought into conversations around? Because we've found a lot, particularly on the island where we have a limited population pool that we are supporting. The CDC programme was designed with this focus on physiology testing, and then at the same time enhanced testing has been offered within our GP practices, and it sometimes feels that we're working at odds with one another.
I think there are conflicting things going on. We have to, as an ICB, to make sure we commission the services to cover all of our population, and the CDCs that we have don't cover our entire population. So we do need to have an offering in primary care in certain areas where the CDCs won't cover. I think that funding and the CROF is often a driver for primary care, and pheno will make up part of CROF because it's the easiest of the tests to do, of the specific tests to do for them. So there will be a desire to have pheno in primary care. I don't think it's necessarily a bad thing to have provision in more than one place, or in more than one service. But I can understand what you're saying about services being at odds with each other. Yeah. I presume you're paid per test by NHSE directly, aren't you? So you want that work.
At present, so the CDC programme has been kind of funded separately to date, but there is view that I think by the end of this coming financial year, we'd then be moving into a similar arrangement to the trusts. But the national team have set minimum testing requirements that are incredibly high, and I think most CDCs are struggling to reach those. For us on the island, we've then found that if our GP practices are our main referrer, if they can deliver the tests themselves, we're not necessarily seeing those referrals, but we've naturally got a trained and skilled workforce in place to deliver some of that. So that was all, but thank you, that's helpful to understand.
So we have actually come to the end of the time allocated for this meeting. If anybody's interested, wants to stay on, you can, and we'll have a look at the questions afterwards as well. But if you need to leave, please do. That's absolutely fine. Has anyone got anything else to discuss? Okay, Paul.
I don't know. I don't know if Stephanie's still on the call. I was just interested in whether for the Isle of Wight service, whether they receive the same payment for testing a child as for an adult, because that's something that's come up in discussions in other areas.
I would just need to double check, but I can come back to you in the chat and confirm. That's not a problem.
Because I guess that would be a bit of a barrier if centres, because centres will obviously take a bit longer with a child to test a child than an adult, and if they're only receiving the same payment, that would be a disincentive to introduce a CYP pathway.
Okay. All right,
I
okay.
actually have an answer on that. I've just very quickly looked through the information. So at the moment, the rate is the same. So we're offered a tariff for spirometry, and we are then offered a separate tariff for spirometry with bronchodilator. But all of it applies to both adults and paediatrics.
Right. And if you do pheno, you get, is there an additional tariff for that? Yeah.
There is indeed, yes.
Right. But yes, that so that in practical terms, that will act as a disincentive for CDCs taking on testing children. So that that is something that ought to be looked at. Thanks. Thank you. That's helpful.
And I wonder if Catherine could have a look at that funding stream and whether you can access that as well. Potentially. I don't know
Well,
how that would work.
we already bill for the tests through the outpatients tariff. Yeah.
Oh, okay. Oh, that's good then. So there's a little
I
bit
think
of
if you
funding
compare the
benefit.
tariffs, though, you get more in the CDC. The tariff is higher. Steph can confirm that, but I'm pretty sure the tariff we get in acute is lower than the tariff we get in the CDC.
I think we'd
that is
struggle,
the case,
Catherine,
yeah.
anyway, if we with more capacity. I don't know we'd manage much more capacity anyway, would we? We don't want to be encouraging people to come to us, really.
So I think the Southampton CDC is going to be opening very soon. So we're here, and Hannah Burke, Dr. Hannah Burke's the respiratory lead for that. So I'll send her the recording for this anyway, because she'll probably be interested. And we'll try and network in with the CDCs and see if they're interested in getting that funding anyway. Because that would be useful, wouldn't it? So there isn't many questions particularly, but I'll have a look through them and respond. But thank you ever so much for all your time today, and thank you to the speakers. That was really generous of you to come today, and really interesting to hear what everyone's doing. Hopefully we'll all become all joined up in the future, but let's keep in touch. And we've got another meeting in June, so if you'd like to attend that would be fantastic.
Oh, hi there. I was wondering if I could cancel a class I'm booked onto at 6
Thanks,
this
Emma.
evening. I think I'm
No worries, thank you.
And just to say, in the meantime, I've put the link for the webinar at the end of March into the chat there, if anyone wants to sign up for that.
Yes, lovely. I'll advertise that. I'll share it as well. Thank you.
Thank you.
Yeah, that's great. I'll keep sharing that as well. That's brilliant.
Brilliant.
Thanks very much.
Everyone. Bye.
Bye.